Hello, friends. Welcome back to another episode of Retina Channel Podcast. I'm your host, Kayvon Pushan. Today, I'm joined by Dr. Andrea Montesel, a medical retina specialist and a researcher currently based at the famous Jules Gonan Eye Hospital in Lausanne, Switzerland. Dr. Montesel trained in Italy and further did his subspecialty training at Moorfields Eye Hospital in London, UK. And over there, he developed a strong clinical and research focus on anti-VEGF therapies and inflammatory complications associated with these injections. In this episode, we discuss his recent real-world study examining intraocular inflammation associated with Faricimab therapy. They used a large-scale data set from Moorfield Eye Hospital, and they looked at the incidence, timing, and clinical characteristics of these events and what they mean for our day-to-day practice. I think it's a highly relevant and practical conversation and helps us put emerging safety data into perspective and helps us discuss these things in combination with the efficacy data that we have when we consult our patients about their treatment options and what that means for them going forward. Well, without further ado, this is Dr. Montesel.
Hello,
Hi, how are you?
Montesel. How are you?
Very good, thank you.
Well, great to have you on the Retina Channel Podcast.
I'm really glad to be here. Thank you for the invitation.
It's my pleasure to have you. Thank you for accepting my invitation. Dr. Montesel, this is primarily a journal club, as you probably know. And then you published an article, your team published an article in Retina on Faricimab and real-world analysis of intraocular inflammation occurrence with Faricimab in patients who had neovascular macular degeneration or diabetic macular edema out of Moorfields. And the results, you published it on the 1 year results, and I know you probably have longer data if you're able to talk about it. And so this is very important for us because Faricimab is fairly new. I mean, we've been using it for a couple of years, but sort of real-world evidence of intraocular inflammation has always been a concern about any new drug. So I'm very happy that you put this together and give our clinicians like myself some data about the occurrence of Faricimab intraocular inflammation. So if that's okay with you, I'm just going to give the gist of the article to listeners and the viewers, and maybe we'll just delve into more details with you. Is that all right?
Yeah, perfect.
Perfect. So this was retrospective. You had, in this particular publication, about 10,000, just over 10,000 injections. And you looked at people who essentially came to emergency room with symptoms of intraocular inflammation, primarily anterior uveitis. And you looked at how many of them came, and you had, I think, about 20 patients or eyes who came back with intraocular inflammation. And none of them had sort of posterior uveitis. None of them had occlusive vasculitis, thankfully. And you come to an occurrence, I think about just under 1% per patient over the span of a year, I think 0.86% or so. And then an occurrence per injection of, I thought about one every 2,000 injection. So just under that maybe. Um, uh, is that close to reality?
Yeah.
Yeah, perfect. So, Dr. Montesel, how did you put this data together? I know in Moorfields and the UK system, you guys for the EMR system. In Canada, it's more fragmented. We don't have that much of a cohesive system. So, how did you put this data together?
So the data came from a single center, and we used the same electronic data records. So it was easy for us to pull out the data. So this was a retrospective analysis using keywords in electronic medical records, keywords like uveitis, inflammation, faricimab. So we had a list of patients that met this criteria, and then we screen manually this patient like a clinician, review the files to see if the diagnosis of intraocular inflammation could be applied to the case.
Mm-hmm, mm-hmm. And so the cases of intraocular inflammation, is it you pick them up just based on patients' reports if they came back to the clinic, or the emergency department, or were they examined after every injection? How was that picked up?
So this is quite interesting because not all the patient went to the emergency department complain of symptoms. We pick up a good proportion of patients just a follow-up visits. So this means that inflammation wasn't real severe. So there was like a mild anterior chamber inflammation the patient wasn't really aware of. So of course we got a proportion of patients that were complaining with a red painful eye and they attended A&E, but another group of patients they were not aware of having inflammation and we just diagnosed this at a follow-up visit.
Interesting. So do you normally examine every patient after an injection, or how was the procedure?
Not all the patients. We do what we can call an approach where not all the patient is seen at the slit lamp. But if the patient we didn't find the same visual acuity as the last visit, or there is some sign on the CT that is not really what we are expecting, we are examining the patient at the slit lamp. And of course, all the patients that attended A&E, they were fully examined with a slit lamp examination.
Okay, so not everyone was symptomatic, essentially.
Exactly.
Okay. And then you had over 10,000 or so injections over a span of a year with Faricimab, and you had 20 cases of intraocular inflammation, correct?
Yes.
And what were different ranges of this type of inflammation? What anterior uveitis, retinitis,
Yeah, basically all the patients had some kind of anterior involvement, meaning KPs or cell in the anterior chamber. So we can say that all patients develop an anterior chamber inflammation, but only about 20% of patients has a kind of vitritis. And interestingly, we didn't find any case of posterior involvement, meaning vasculitis or hemorrhages or something funny at the back of the eye.
And all these cases with complication, they had the fluorescein angiography to confirm lack of posterior involvement?
Not all the patients, to be honest. So probably we missed some cases of subclinical vasculitis or subclinic occlusive vasculitis. This it can be a risk because this was a retrospective analysis. But if the patient attended, for instance, with some vitritis and no signs of vascular involvement, can happen that he didn't have an angiogram.
Makes sense. I mean, IVFA is an invasive test and we don't routinely do it in everyone. So I guess if you're not suspected posterior involvement, you wouldn't bother with an IVFA. Exactly. Makes sense. Okay. And so about 20 cases. Now, how did they do these 20 people after they had intraocular inflammation?
So this is very interesting because, of course, at the moment of the diagnosis of the inflammation, the visual acuity was statistically significant lower than at baseline. So during inflammation, there was a decline in visual function. But we found out that at final follow-up, there was no changes in the visual acuity. So the visual acuity will recover to the level before the inflammation. So we can say that it did well, mainly because it's an anterior inflammation and it's generally mild. And they were managed mostly with topical steroids. Only one patient needed a supplement of oral steroids.
So they all came back to their baseline. And in that part, I think the study spanned a period of 2022 and 2023 for a year inclusion. Yes. At that time, there was no pre-filled syringes for Faricimab. These are all vials drawn by clinician or drawn by the pharmacy. How does it work in terms of administration from the vial or PFS?
Yeah, so at that time, the patient were administered with vials. Now we are spending our research because now we are analyzing data up to 3 years. So in this period, we have both vials and we have both pre-filled syringe. This is something that we are currently doing, so I cannot say anything about.
Sure.
but it's something that we are looking at, if there is any difference between vials patient and pre-filled syringe.
Okay, fair enough. And for this study, what was the rate in terms of, like, I'm a clinician, I'm injecting Faricimab into someone's eye with neovascular AMD. I want to consent them in terms of IOI. Based on your study, what should I tell them? What's the rate?
Well, you can tell them that we are using now what we call a second generation anti-VEGF that is probably more powerful than the first generation that has been the standard of care since now. And what I usually try to say to this patient is that these drugs are more powerful, so probably we can have a better effect in the long term in terms of having an more durable effect. But this more powerful effect comes also with a very, very little risk of generating an inflammation inside the eye. This inflammation, if it happens, is generally mild and reversible, so they don't need to worry too much, but they just need to be vigilant. If they experience some symptoms the day after the injection, they need to inform us and to come back to clinic to be examined.
Makes sense. So your study essentially confirms the safety of Faricimab for these purposes.
Yes, where we saw that, yes, probably Faricimab has a slightly higher risk of intraocular inflammation compared to aflibercept or ranibizumab. But this risk is, if we think about the risk and benefits, I think the benefits of having a more long-lasting effect balances this risk of a slightly higher risk of intraocular inflammation.
Gotcha. And does this risk of IOI match what they had in Tenaya Lucerne, their pivotal studies, or is it lower or higher compared to their pivotal studies? Or is it the same ballpark?
It actually matches. Actually, in our study, it was a little bit lower, but this is because our study was a real world study. And when you're working in a high volume center, probably you're going to miss some very subtle cases. Why in a more regulated clinical trial, you detect even the less severe cases.
And so I remember from your article, you had about 0.86 or less than 1% per patient or per eye for the course of the year. So that's 1% or less is a chance any single patient would have some inflammation at some point over the year.
Yes, I think the rate in the registration trials was up to 2% per patient.
So this is less than registration trial.
Exactly.
Very good. And most of these people who had inflammation in your study, they had in the first few injections. Is that correct?
Yeah, I mean, this is something very interesting. What I found fascinating about intraocular inflammation is something that is not fully understood. So it's a phenomenon where there are some patient factors, because we know there are patients that had anti-drug antibodies. There are patients that are prone to have a more inflammatory environment because they are in MD. We got some complement dysregulation. In diabetics, we got disruption of the blood retinal barrier. So there are definitely some patient factors, but there are also some molecule factors because we got different molecules with different designs. We can also have impurities in the molecules, and then we got the delivery factors. So we got the presence of droplets of silicone in a syringe. We got the way the molecule is storage and is handled. So there are very, very factors involved in this process, and we don't know how the inflammation occurs. And it probably occurs in the first injection in our study because it was a 1 year study, so not all the patients had, 10 injections. So most of the patients had less than 5 injections. So this is mostly the reason why this population has got inflammation after 3 or 4 injections. But again, it's a phenomenon that is not really fully understood.
Yeah, it's very interesting. And I suppose none of these were true infections, and you must have excluded people probably who came with overt endophthalmitis. Is that correct?
Yeah, so this is one of the main point of the intraocular inflammation that
Hmm.
it's crucial to distinguish from sterile inflammation and from infectious endophthalmitis.
Hmm.
How can you do that? Well, it's not always simple. Let's say that generally speaking, when you got an endophthalmitis, the symptoms and the signs, the clinical signs, are more striking. Also, endophthalmitis tends to occur in a more acute way, so after 2 to 4 days, and while intraocular inflammation can happen after even up to a month after the injection.
Hmm.
And so these are the clinical signs that can differentiate between the two entities.
Hmm.
But if you are in doubt that this patient has an infectious endophthalmitis, you should treat as an endophthalmitis.
Gotcha. And your timeline was anywhere from, I think, 1 day to 30 days, average of 8.5 days. So it was
Exactly.
longer generally than standard endophthalmitis, I think. Okay. And you mentioned about patient factors. Did anything pop up as potential risk factor for a patient? Some studies, with other drugs, if you remember, we talk about the females being more prone to certain types of inflammation or maybe background of autoimmune diseases. Anything that popped up in terms of patients who had this type of intraocular inflammation post Faricimab?
Yeah, of course, if the patient has a background of previous uveitis or autoimmune disease, is more prone to develop intraocular inflammation. Female have a slighter proportion of a slighter increase in risk of inflammation, probably again because they are more prone to autoimmune disease. In our investigation, we tried to see if there was any difference in between naive patient and switch patient, and also if there was any difference between AMD patient and diabetic patient, but we didn't find any statistically significant differences between these
Mhm.
groups.
Mhm. But did that show in your study that females and people with background of autoimmune disease were more
No, this
prone
is
or
something
no?
that is present in the literature, but we
Okay,
didn't
so
find
you
any.
didn't find that. You didn't find that. Okay, wonderful. And are you able to tell us anything about your 2 year or 3 year study results? Or is that more or less matched with what you showed in the 1 year?
So we can say that now we're analyzing data up to 3 years, and we got more than 5,000 injection. That is quite impressive number. And our results are reassuring because we found out that during these 3 years, the rate of the incidence rates of intraocular inflammation more or less remains the same. What we found out also some cases of occlusive vasculitis that we didn't
Mhm.
pick up in the first years. But this is something that is very, very rare, and
Mhm.
is something that is consistent with rates already described in literature. So we are talking about mm, overall one every 10,000 injection. That if we consider like endophthalmitis is like 5 times less frequent than infectious endophthalmitis. So it is present, but it's very, very rare.
Very rare. Gotcha. Um, okay, so thank you for sort of alluding to that. So we'll wait for the publication to come out as well. Very nice. So Dr. Montesel, anything we missed, anything you want to talk about your very informative publication? Because these things are important because as clinicians start to use them, we've been burned before by new drugs, coming out afterwards and giving us trouble. So this is very reassuring to see Faricimab has been functioning well in a retrospective large scale data set. Anything you want to add to your conversation and your sort of publication discussion?
Well, what I can see basically to summarize the study is that the risk of intraocular inflammation, it is there, it's real, it's very limited, but it's there. So it's crucial to be aware of this risk and to identify the intraocular inflammation and to differentiate, if possible, from the infection and endophthalmitis. I can say also that when inflammation occurs, it's usually mild and is not associated with visual loss. It is associated with visual loss if if it presents with an occlusive vasculitis, but this is extremely rare. Um, what I can say also that the exact mechanism is not really fully understood, so there is room for more research and more investigation, and is a very hot topic, and is very. I encourage people to do research in this field. Also, it's important to report these cases. Uh, it's important to report to increase the awareness, and also because you need to report side effects. And what will be nice, it will be to create national registers for this kind of side effects to highlight potential hazards for our patients.
Thank you very much. Well, I want to thank you, Dr. Montesel, for coming to Retina Channel Podcast. Our time differences, you're in the UK, I'm in Canada, so I know. Thank you for staying up and arranging this. And I wish you all the best in your future endeavors. And thank you for publishing this work.
Thank you for the invitation, and it was a pleasure speaking to you.
Okay, friends, this wraps up episode 95 of the Retina Channel Podcast. Thanks again to Dr. Andrea Montesel for joining us from Europe and sharing his insights on the importance of intraocular inflammation in association with Faricimab, commonly known as Papasavvas. I was really encouraged by real-world safety data for Faricimab, knowing that it's in line with what we expect and there was no major signals against it. But also, I was reminded about the importance of early recognition, early vigilance of intraocular inflammation, especially during the early initial treatment phase. If you enjoyed this episode, don't forget to subscribe to Retina Channel Podcast if you haven't already subscribed to it. Remember that the episodes are both on all the podcast platforms and the YouTube in the video format. And you can look for it at the Retina Channel. And as always, thanks again for listening, and we'll see you in the next episode.